In any high-performance orthodontic practice, energy is a finite and precious resource. We spend a tremendous amount of time auditing our physical waste, the materials left on trays, wasted chair time, or overhead expenses. But we frequently overlook a much more insidious drain on our momentum: linguistic waste. The words and phrases your team uses every single day are not just neutral sounds, they are either catalysts for efficiency or black holes that suck the professional drive right out of your clinic. If you find yourself constantly clarifying vague instructions or stepping in to fix minor errors, you aren't just dealing with a personnel issue. You are witnessing a failure in your system documentation that has manifested in the team's vocabulary. As leaders and entrepreneurs, we must recognize that shared language is the bedrock of treatment acceptance and operational excellence. To reach that next level of scalability, we must identify and eliminate the deadly terms that signal stagnation and powerlessness. Let's look at the first offender: the phrase, "I hope so." On the surface, it sounds optimistic, even polite. We hope the patients are on time. We hope the afternoon schedule won't collapse into chaos. But in a lean orthodontic environment, hope is not a strategy. It is a declaration of powerlessness. It suggests that the outcome is entirely in the hands of luck or external factors beyond our control. When a team member relies on hope, they are effectively resigning from their responsibility to manage the system. They are externalizing the results and removing their own internal locus of control, which prevents them from proactively solving potential problems. To improve performance, we must replace hope with a commitment to definitive protocols. Instead of hoping for a smooth flow, the team must state exactly what they will do to ensure it, whether that is pre-staging trays, proactively confirming complex cases, or implementing if-then logic. If a patient hasn't confirmed by 9 a.m., then we execute a specific diagnostic confirmation protocol. This simple shift puts the control back into the hands of the professionals and moves the practice from a passive state to an active, proactive environment. Then there is the ultimate finality: "I can't." This phrase acts as a brick wall that stops professional development in its tracks. Most of the time, "I can't" is actually a placeholder for "I haven't learned how yet," or "I am afraid to fail." It creates a dependency trap where you, the doctor, become the only person capable of solving a problem, whether it's a difficult insurance verification or a minor appliance adjustment. This makes you an unnecessary bottleneck and severely limits your ability to scale. The response to "I can't" should never be punishment, but immediate calibration and coaching. We must encourage our colleagues to rephrase this as, "I am looking for the solutions to make this possible." This keeps the door open for targeted training and ensures the patient journey is never hindered by a lack of confidence. It forces the team to articulate the why behind their limitation, which often exposes a gap in your standard operating procedures or a missing training module that requires your attention. True delegation is only possible when tasks are standardized, removing the ambiguity that necessitates the phrase, "I can't." Finally, we have the word try. In a high-stakes clinical setting, try is often a pre-built excuse for failure. It suggests that effort was made, regardless of whether the result was actually achieved. But vague commands like, "try to organize the clinical cabinet," invite poor results and wasteful rework. We need precision protocols to replace trying. An instruction must define the desired outcome and the required metric for success before the task is even assigned. For example, instead of asking someone to try, we say, "The clinical cabinet must be organized according to the new SOP by 5 p.m. today, and a photo of the final result must be uploaded to the knowledge portfolio." When you hear, "I'll try my best," the correct leadership response is to press for definiteness. Ask them to describe the first 3 concrete actions they will take. This eliminates the waste of rework and forces a solidification of commitment to the action. This discipline of immediate action fosters momentum and creates psychological closure, allowing the team to operate in a high-performance flow state where errors are prevented and quality is consistent. Language is the foundation of your practice's autopilot system. By systematically removing "I hope," "I can't," and "I try," you foster a culture of discipline and ownership. This refinement ensures that your team remains high-performing even during the busiest rushes, allowing you to lead with calm confidence rather than being a perpetual firefighter. When your team is empowered to own the outcomes, whether it's the conversion rate or the efficiency of a treatment room, their professional satisfaction and engagement skyrocket. They move from passively following tasks to actively managing results. This strategic shift transforms you from a doctor who constantly intervenes into an architect of sustainable excellence, ensuring both longevity and consistent clinical success. Thank you for your time, and I'll see you in the next video.